Welcome to our video on plasma cell disorders. Let's get started. Here are the topics that we'll be discussing in this lecture. Let's begin with multiple myeloma. With regards to multiple myeloma, we'll discuss the definition, pathophysiology, clinical features, diagnosis, and management. Multiple myeloma is defined as a malignant proliferation of clonal plasma cells, which results in the overproduction of monoclonal immunoglobulins, particularly IgG and IgA. It predominantly affects the elderly, and peak incidence is in the 7th decade of life. Let's briefly discuss some important points of pathophysiology. In multiple myeloma, neoplastic cells activate receptor activator of nuclear factor kappa B, or RANK, on osteoclasts. Thus, osteoclasts are activated, which leads to bone destruction, osteolytic lesions, and hypercalcemia. Also, when the bone marrow is infiltrated by neoplastic cells, this leads to the disruption of normal hematopoietic cells and the bone marrow microenvironment, which ultimately results in anemia, leukopenia, and thrombocytopenia. It's important to note that monoclonal immunoglobulins lack antigenic diversity, so overproduction of these immunoglobulins in multiple myeloma leads to an increased risk of infections. Finally, free light chains can be produced heavily and deposit in tissues, leading to primary amyloidosis. They can also deposit in kidney tubules, which can lead to renal failure. Based on the pathophysiology, we can easily expect some clinical features of multiple myeloma. To make them easier to remember, let's use the mnemonic CRAB. C in CRAB stands for hypercalcemia. So the patient can present with symptoms of hypercalcemia, including abdominal pain, muscle aches, constipation, and depression. R in CRAB stands for renal failure. A stands for anemia, which can present with fatigue, dyspnea, exercise intolerance, and pale conjunctiva. Finally, the B stands for bone pain, which most commonly involves the back, jaw, chest, or arms. Possible but less likely presentations in multiple myeloma are recurrent infections and pathologic fractures. All right, let's try a quick question. How does multiple myeloma lead to the overproduction of immunoglobulins, but also increases the risk of infections? All right, as we just discussed, multiple myeloma leads to the overproduction of monoclonal immunoglobulins. As you know, immunoglobulins or antibodies typically protect the host from infections as they're part of the adaptive immune system. However, in the case of multiple myeloma, these overproduced immunoglobulins lack antigenic diversity and are therefore not very useful to the immune system in protecting against various infections. All right, now let's discuss the diagnosis. Serum protein electrophoresis is the most important screening test and best initial test. It detects elevated monoclonal immunoglobulin, also called M protein. Serum immunofixation is performed to confirm the presence of M protein and identify its type. In multiple myeloma, immunoglobulins produced are usually IgG or IgA. A serum free light chain assay can also be performed in the initial screening with an SPEP, which again stands for serum protein electrophoresis. It helps measure the concentrations of kappa and lambda free light chains in the serum. A 24-hour urine protein electrophoresis can also be performed to detect M protein in the urine. Performing urine immunofixation can also be useful. It's important to note that the urine dipstick is negative in multiple myeloma since it mainly detects albumin. A CBC and blood smear are usually ordered in routine evaluation as well. A CBC can show low hemoglobin and hematocrit due to anemia. Usually the MCV is normal and the patient has a normocytic anemia. On blood smear, rouleau formation can be seen. Other lab studies that are often ordered include serum calcium, creatinine, total protein, and albumin. The serum calcium is usually elevated due to bone destruction by neoplastic cells that activate RANK on osteoclasts. Creatinine can be elevated if there is renal involvement. Total protein is usually elevated, but patients have normal levels of albumin. This leads to the presence of a protein gap in which the difference between the total protein and albumin is larger than 4 grams per deciliter. A bone marrow biopsy is the most accurate test, and this will show more than 10% abnormal plasma cells with clock face chromatin. Lastly, on imaging, including CT, MRI, and PET CT, osteolytic lesions may be seen. Here's an image of a normal serum protein electrophoresis. And the bottom image shows monoclonal gammopathy in a serum protein electrophoresis. Note the M spike right here, which is due to the proliferation of monoclonal antibodies. Here is a peripheral blood smear of a patient with multiple myeloma, and we can see rouleau formation, which is right here. Note the stacking of red blood cells. Recall from step 1 that rouleau formation is associated with elevated serum protein levels. Here's a histopathological slide showing a bone marrow biopsy from a patient diagnosed with multiple myeloma. Note the clock face nuclei of neoplastic cells. After verifying the diagnosis of multiple myeloma, we move on to management. All patients should undergo assessment of eligibility for autologous hematopoietic stem cell transplantation. Chemotherapy is an essential part of treatment. Some agents that can be used include bortezomib, lenalidomide, daratumumab, cyclophosphamide, and dexamethasone. The choice of initial chemotherapy regimen depends on risk stratification, as well as eligibility for autologous hematopoietic stem cell transplantation and evaluation for comorbidities. It's worthy to note that bortezomib, which is a proteasome inhibitor, is associated with a risk of peripheral neuropathy. Lenalidomide is associated with a risk of thrombosis. Therefore, antithrombotic prophylaxis should be considered if a patient is prescribed this medication. The use of osteoclast inhibitors is recommended in all symptomatic patients who have osteolytic lesions detected by imaging or osteopenia or osteoporosis detected on bone densitometry. Agents that can be used include bisphosphonates or denosumab. Recall that denosumab is a monoclonal antibody against receptor activator of nuclear factor kappa B ligand, or RINK-L. Before we end this topic, let's go through this algorithm as a recap. If a patient presents with general signs and symptoms of a plasma cell disorder, such as fatigue, weight loss, or recurrent infections, we begin by investigating the CRAB findings. If some or all of them are present, multiple myeloma is suspected, and diagnostic procedures should be performed, such as an SPEP, immunofixation, lab studies, and a bone marrow biopsy. When multiple myeloma is confirmed, we move on to management. This includes hematopoietic stem cell transplantation, chemotherapy, and osteoclast inhibitors. All right, now let's move on to our second condition here, which is Waldenstrom macroglobulinemia. Again, we'll discuss the definition, pathophysiology, clinical features, diagnosis, and management. So, beginning with the definition, Waldenstrom macroglobulinemia is defined as a malignant proliferation of clonal B cells, which leads to the overproduction of monoclonal IgM. It can also be called lymphoplasmacytic proliferative disorder. All right, moving on to the pathophysiology. It's characterized by the overproduction of IgM, which leads to several manifestations. First, it increases the viscosity of the blood, and this is due to the pentameric configuration of IgM. Second, IgM can precipitate out of the serum in cold temperatures, leading to cryoglobulinemia. Third, IgM can act as an autoantibody against some nerve components, which can lead to neuropathy. Also, infiltration of hematopoietic tissues by neoplastic cells leads to cytopenias, such as anemia, as well as hepatomegaly and lymphadenopathy. Patients commonly present with constitutional symptoms, such as fatigue, weight loss, and night sweats. Hyperviscosity syndrome is a clinically significant presentation because it's considered an emergency. This includes headaches, dizziness, blurry vision, tinnitus, and bleeding. Also, dilated, segmental, and tortuous retinal veins can be seen on fundoscopy. The patient can also present with peripheral neuropathy, as well as symptoms and signs of anemia, such as exercise intolerance and pale conjunctiva. On physical examination, lymphadenopathy and hepatosplenomegaly can be encountered. All right, let's try a question. Patient comes in for follow-up on their Waldenstrom macroglobulinemia and notes that recently their fingertips seem to lose color and feel slightly numb, especially when it is colder outside. How is this new symptom related to their past medical history? All right, this patient has a history of Waldenstrom macroglobulinemia. With this disease, one of the things we need to watch for are symptoms of hyperviscosity syndrome, which is considered a medical emergency. The patient's newest symptom is that of Raynaud's phenomenon, where the distal arteries of the extremities undergo excessive vasoconstriction in response to colder temperatures, which leads to discoloration from ischemia. In a patient with Waldenstrom macroglobulinemia, we know that the overproduction of IgM can lead to cryoglobulinemia, which is when IgM precipitates out of the serum in response to colder temperatures, which in turn impedes normal blood flow. This reduction in blood flow leads to a much more significant reduction in blood flow when arteries vasoconstrict when compared to a healthy patient, which is why this patient is experiencing Raynaud phenomenon more readily. So Raynaud phenomenon can be a symptom of the hyperviscosity seen as a result of Waldenstrom macroglobulinemia. However, in the absence of other symptoms of hyperviscosity syndrome or symptoms of severe ischemia in the affected extremities, Raynaud phenomenon is not considered a medical emergency and is typically treated by avoiding the trigger, which is most commonly colder temperatures. The diagnosis can be achieved by clinical presentation, SPEP results, and bone marrow biopsy. SPEP detects the presence of M protein. Immunofixation helps determine the type of M protein. In Waldenstrom macroglobulinemia, The clonal immunoglobulins produced are usually IgM. A bone marrow biopsy will show infiltration of more than 10% of small lymphocytes, likely with intranuclear IgM-containing vacuoles, also called Dutcher bodies. Other likely findings include anemia on a CBC and rouleau formation on a blood smear. All right, now let's move on to management. For asymptomatic patients, no treatment is needed. However, observation and follow-up are necessary. Hyperviscosity is considered a medical emergency. Thus, patients require emergency plasmapheresis to remove the excess IgM from circulation. For most symptomatic patients, initial treatment with chemotherapy plus rituximab is preferred. Recall that rituximab is a monoclonal antibody against CD20. It's important to note that rituximab can be associated with a transient increase in IgM levels after administration. Therefore, monitoring should be considered during the first and second cycle of administration. Also, plasmapheresis may be performed for patients with high IgM levels before receiving rituximab. All right, so going back to our algorithm as a recap, if a patient presents with general signs and symptoms of a plasma cell disorder, such as fatigue, weight loss, or recurrent infections, and no CRAB findings are present, but there are signs or symptoms of hyperviscosity, such as headache, dizziness, or blurry vision, Waldenstrom macroglobulinemia should be suspected, and performing diagnostic procedures should be done to confirm the diagnosis. These include SPEP, immunofixation, a bone marrow biopsy, and a blood smear. Management is with chemotherapy, rituximab, and plasmapheresis. All right, now let's move on to our next condition, monoclonal gammopathy of undetermined significance, or MGUS. This is defined as a pre-malignant proliferation of clonal plasma cells, or B cells, which leads to the overproduction of immunoglobulins. It can progress to more advanced disease, and the risk of progression is about 1% per year. IgM MGUS can progress to Waldenstrom macroglobulinemia, and IgG or IgA MGUS can progress to multiple myeloma. MGUS is asymptomatic and is usually discovered incidentally. The diagnosis of MGUS is made by the presence of a triad of findings. First, SPEP detects M protein, typically lower than 3 grams per deciliter. Second, there are less than 10% clonal plasma or lymphoplasmacytic cells in a bone marrow biopsy. And third, it's important to note that the patient has no CRAB findings that are associated with multiple myeloma and no evidence of end organ damage, such as lymphadenopathy, hepatosplenomegaly, or hyperviscosity. No treatment is needed in MGUS. However, close observation and evaluation over time should be considered. So going back to our algorithm, as we mentioned, MGUS is typically asymptomatic, so there are no CRAB findings nor symptoms of hyperviscosity. However, serum protein electrophoresis and bone marrow biopsy are used to confirm the diagnosis. Only monitoring and close observation are needed. All right, let's move on to our last condition, amyloidosis. And with regards to amyloidosis, we'll discuss the definition, systemic amyloidosis, localized amyloidosis, diagnosis, and management. Amyloidosis is defined as extracellular deposition of abnormal amyloid fibrils, which leads to cellular damage and apoptosis. The amyloid protein has a beta-pleated sheet configuration, and deposition of amyloid can be either systemic or localized. Systemic amyloidosis affects multiple tissues or organs. We'll go through some common types. The first is amyloid A, or AA amyloidosis. It results from deposition of fragments of the acute phase reactant serum amyloid A, or SAA. It's associated with chronic infections or inflammation, such as rheumatoid arthritis, as well as certain tumors, such as renal cell carcinoma and Hodgkin lymphoma. The second type of systemic amyloidosis is AL amyloidosis. It results from the deposition of immunoglobulin light chain fragments and is associated with plasma cell dyscrasias, such as multiple myeloma or Waldenstrom macroglobulinemia. The third type is dialysis-associated amyloidosis. It results from the deposition of beta-2 microglobulin, most commonly in joints, and it's associated with long-term dialysis, for example in patients with end-stage renal disease. Since systemic amyloidosis affects multiple tissues and organs, it can have multiple and different presentations. When the heart is affected, the patient can have restrictive cardiomyopathy and arrhythmias. When the kidney is affected, asymptomatic proteinuria or nephrotic syndrome can result. When the GI system is affected, it can cause hepatosplenomegaly and macroglossia. When the musculoskeletal system is affected, it can result in arthropathy and carpal tunnel syndrome. And finally, the patient can present with peripheral neuropathy if the neurologic system is affected. All right, now let's move on to localized amyloidosis. This affects a single organ. It can be seen in several conditions. In Alzheimer's disease, beta amyloid protein deposits in the brain, which is cleaved from beta amyloid precursor protein. In medullary carcinoma of the thyroid, deposition of calcitonin is detected. There can also be islet amyloid polypeptide deposits in pancreatic islets in patients with type 2 diabetes mellitus. And finally, in systemic senile amyloidosis, normal transthyretin deposits mainly in cardiac ventricles. All right, now let's move on to the diagnosis and management. It's best diagnosed via tissue biopsy. On an H&E stain, amyloid appears as amorphous eosinophilic material. On a Congo red stain, apple green bifurengence under polarized light is detected. Management is achieved by treating the underlying cause. For example, treating the chronic inflammatory disease in AA amyloidosis and multiple myeloma in AL amyloidosis. All right, let's try a question. A patient coming in multiple times a week for dialysis mentions to one of the nurses recent symptoms of pain and numbness in the forearm, wrist, and hand. It seems to mainly affect the thumb, index, and middle fingers. What is the cause of the patient's new symptoms? All right, this patient is receiving regular dialysis treatments, so we can safely assume they're in renal failure. Additionally, they have a new symptom of pain and numbness in the distal upper extremity that seems to mainly affect the thumb, index, and middle finger. This presentation should make you think of carpal tunnel syndrome, which is caused by compression of the median nerve and leads to symptoms in the areas innervated by the median nerve, as seen in this patient. As we know, renal failure can lead to dialysis-associated amyloidosis, which is a systemic amyloidosis and is caused by the deposition of beta-2 microglobulin, specifically in the joints, and this can lead to arthropathy and carpal tunnel syndrome. So this patient's new symptom of carpal tunnel syndrome is caused by dialysis-associated amyloidosis. The typical management of amyloidosis involves treating the underlying condition, but in this cause of renal failure, there's not much more that can be done. However, we can treat the carpal tunnel syndrome with immobilization of the wrist via a splint for now and see how the patient does. Here's an H&E stain showing hepatic amyloidosis. Note the amorphous eosinophilic material, for example, right here. Here is another histopathological slide showing the hepatic amyloidosis stained with Congo red. Note the apple green bifurengence under polarized light. All right, let's end this lecture with a final question. A 65-year-old man presents with increasing pain in his forearm over the past 4 months. He has also had a low mood and severe constipation during this period. CBC findings are consistent with normocytic anemia. An X-ray of his forearm can be found below. What is the best next step in management of this patient's condition? A. Administer bisphosphonates. B. Perform a Congo red stain. C. Serum protein electrophoresis, or D. Forearm bone biopsy. All right, this is an elderly patient who now has pain in his forearm, along with complaints of low mood and severe constipation. These findings should make us think of hypercalcemia, and on the X-ray, we can see osteolytic lesions. The combination of bone pain, hypercalcemia symptoms, normocytic anemia on a CBC, and the presence of osteolytic lesions in an elderly patient makes multiple myeloma a very likely diagnosis. So what is the next step in management here? The correct answer is C, serum protein electrophoresis. This is the most common screening test for multiple myeloma, as well as Waldenstrom macroglobulinemia and monoclonal gammopathy of undetermined significance. The diagnosis can then be confirmed by a bone marrow biopsy. Answer choice A is incorrect because even though bisphosphonates are a treatment option for multiple myeloma, we must confirm the diagnosis before treating the condition. Answer choice B is incorrect because a Congo red stain would not help diagnose multiple myeloma. However, it is used in the diagnosis of amyloidosis. Option D is incorrect because a forearm biopsy would not help in the diagnosis of plasma cell disorders like multiple myeloma. We would instead need a bone marrow biopsy. Also, a biopsy is a relatively invasive procedure and should be avoided if at all possible. So again, the correct answer is C, serum protein electrophoresis. And that concludes our video on plasma cell disorders.